Cephalometrics was invented for research, but now we begin to use it for clinical reasons. Intrusion wasn't very likely with the standard Edgewise system, so we dropped out the idea we could intrude teeth. So we'd come to precision with precious metals. We went from pinch bands to prefabrication, to the Edgewise system, to steel wire, and the religious doctrine then of one wire to treat a patient. Staples were used for rotation, spurs and tiebacks were used. And what I later labeled the dominance of proximal anchorage. Proximal as related to transformal anchorage. We transfer the anchorage away from the proximal tooth. So it's a Latin term meaning transferring of forces away from the tooth adjacent to it. We went into stages of preparation of anchorage and treatment plannings. But in the beginning with the Edgewise mechanism, the objective was to treat a patient in 3 months. Now keep in mind the vigor of the elastics and the fact that they were trying to do all of the manipulations within the arch at the same time the elastics were being worn. They were trying to standardize appliances and standardize treatment. Then we began to develop different types of brackets. The ideal arch became a very firm doctrine, and cervical anchorage came to be reborn again. Now here's the Edgewise system. It consisted of this kind of a bracket in the beginning and then went to this bracket. The ligature wire was used to ligate the wire into this bracket. Staples were placed to rotate the teeth, and these little washers were placed to advance the wire from the molar tube. So the bracket was soldered onto a band horizontally, and we had this blank then to pinch onto the tooth. The thing was relatively simple. You band the tooth. The bracket could be pre-attached. You banded the molar, and you soldered the tube. Then you put staples on wherever you needed to rotate a tooth. And we started out with one rectangular wire. A lot of people attempted to start with one wire and finish with the same wire. The Edgewise bracket with the staple and the rectangular tube has lasted longer and been more popular than any other technique in history. Here's Brody as I first met him. Extremely intelligent man, and outside of Ango maybe had more influence in orthodontics on a world basis than any other person. But unfortunately, the original Edgewise appliance was too ambitious. They advocated treatment to 3 to 6 months. It came to employ continuous arch systems, a tremendous loss of anchorage in the lower arch. So this went on for a number of years, and later then people came back and started to reinforce their anchorage with extraoral traction. The appliance itself, as far as I analyze it, and this is my opinion, some people may not agree with it, but it's my opinion that the Edgewise appliance, as they used it, directly caused the wave of extraction need that we had in the United States. This continuous arch system with rapid treatment, with continuous elastic traction, mutilated mouths, in my opinion. So by 1936, extraction was advocated again to keep from working the denture into a double protrusion. And particularly when they found in 1938 that they weren't affecting the jaws but only moving teeth, extraction got a further push. So in 1947, when I came into my training in orthodontics, the pendulum had swung. The Edgewise appliance was no longer an expansion appliance, it was a contraction appliance. In 1935, Strang published his book on the Edgewise appliance. It was designed as an expansion appliance. 13 years later, he wrote an article on the fallacy of expansion and fully embraced all of Tweed's concepts. So on the East Coast, they formed a Strang-Tweed study group, which meant expansion or extraction therapy. This is from Brody's publication in 1928, The Rapid Treatment of Class 2. In short, without adding to the speed of movement of individual teeth, it should be able to reduce treatment time from 10 months to 3 months, and even less. So can you imagine that? So this had to be done with second-order bends, which are very hard to explain and very hard to manipulate. And they went then to a full complement of teeth, all the teeth brackets. He bypassed these second premolars back here in his illustration. But all the anterior teeth were bracketed. Started putting in wires, and the idea was to, as rapidly as possible. Now, what's the problem with this appliance? What's the problem with that Edgewise appliance? What's going to happen if I go in there with that amount of crowding and that amount of deep bite? Where the incisor is going to go? This wire is stopped right there, so the wire can't go back any further. If I ligate all of these teeth in here, I've got this tied toward the wire, see? What's going to happen? These teeth are going to roll. That's a round wire. And there's no place for the teeth to go here except in the labial direction. So with a full complement of teeth like you see here, expansion was synonymous with forward movement of the lower incisor. This didn't work like it was diagrammed to be. This, in order for it to happen, would have to move the molar back. But actually what happened with it was these teeth came forward, and these teeth would come up, to be sure. But now he had all of these appliances, and here's the old G-wire, which we later used for retainers. You started out with brass wire separators. Then you soldered it. You trimmed this down. Then you pounded it on. Then you marked it. And then you soldered it on. Now after that you put a brass wire all the way through. Measured, cut off the amount of gold wire that you needed. And you adapted an arch to the malocclusion. What a pain. In the United States in 1934, Dr. Brody had space for 10 graduate students. 2 applied. Only 2 applied. In the whole United States, 2 people wanting to become orthodontists. Isn't that remarkable? Why? Who wanted to? Look how much work it was. When I looked around for orthodontic graduate schools in 1945, there was only 5. And only one of them was recommended. And that was Illinois. The rest of them were just not teaching very many fundamentals. We used round or rectangular wires. And we could put a push coil on here, or we could put a loop on to open up space. This had to be soldered on. It couldn't be bent into the wire. And then we'd just add washers onto the end of this so we could extend the wire. Some people would cut a groove in the end of the wire. Some people would put a staple on the end of the wire. Both of these were very time-consuming. To upright a tooth, we'd put an auxiliary lever by putting it under the staple. And to retract canines, we started putting push coils on all the way around the arch wire. Pull coil springs were used. Excessive space had to be created in order to bring canines in. We would have to tie the staple, activate it this way, and then tie it over to the bracket. So all of these were in the use of the staple and the use of coil springs. Angle started out with the upper canine to canine retainer. And he tucked his laterals in too much, and he left his canines too prominent. The buccal cusps are all in line. In my opinion, this cusp should almost be in the center of this premolar tooth here. So for 2 or 3 decades and still, this image, this erroneous image is still put in orthodontic cases. Right there's the number 1 site of relapse. So I have to take objection to him right there. And today, if we're going to fix a retainer, we'll put it on the bicuspids. Now the results of this led to open bites. But inability to move molars distally because the lower arch came forward. We dare not move the lower incisor forward, and we can't expand. You can't intrude. You can't do anything with the jaws. You can't change the muscles, and you can't predict it. So what can you do? Nothing. Can't do anything except take teeth out and align the teeth, the remaining teeth, within the confines of the arch. Tip the upper teeth back and tip the lower teeth forward. So this is the status of orthodontics when I came into it. This man was the dominant figure in orthodontics in those years. And the Tweed Tertiary Edgewise, just 2 hours away from here. Down here in Tucson. And I knew this man very well, admired him very much. But ultimately I had to disagree. Not on a personality basis, it was just on a professional basis. Because he came to advocate again extraction in about 2 out of 3 patients, with a complete objective of getting his lower incisors exactly upright. He used class 3 elastics to get the lower arch back far enough, and he'd wear elastics, wear extra traction all the way through treatment. Now from there, we took off with Bioprogressive. There's 2 sources of Bioprogressive. One was to correct all of these things that I can see that we were doing that to me were inadvisable. But the causa finalis, the final cause of bioprogressive movement, was to fulfill the indications of a treatment design and a VTO and a growth forecast. In other words, we'd take a patient after the diagnosis, after a growth prognosis, and set the teeth in accordance with an ideal for that individual that we could conceive. So I had to look around and experiment for techniques in which I could bring about the changes that we designed. It all came together in about 1964. I recognized all these problems in about 1950. It wasn't until 1972 that we labeled it bioprogressive. It wasn't until 1960 that I discovered how easy it was to intrude anterior teeth. I don't think that I could have done what we've done without having gone through this evolutionary process, particularly the experience with the ribbon technique. Really, the techniques haven't changed in principle. Really, they haven't. Our understanding of them has changed. Our understanding of the amount of force we need has changed. But the principles, as Angle said, are only a precious few. If Angle would have lived, he would have developed bioprogressive. I can say that with no hesitation, because everything I did was directly in line and consistent with his principles. I had the benefit of seeing what happened cephalometrically, and I was in a position to make changes to try to correct some of the things that he would have seen himself. Why would he have made changes all his life just to stop when he died? Of course he would have done what I did. So as soon as we get having lunch, we'll get back and talk about now the evolution of bioprogressive and the steps we went through in that movement. I think that's a fascinating lecture. It took me a long, long time to put that lecture together. So I hope you appreciate it.